Good afternoon to some, good morning to others, and welcome to today's presentation on physician and burnout. We're going to have a conversation around this very important topic. It's going to be led by two wonderful people who are going to bring their insights into this conversation around physician burnout and wellness. This webinar is sponsored by the HMS Office for Diversity, Inclusion, and Community Partnership. The mission of the DICP is to advance diversity and inclusion in health, biomedical, behavioral, STEM fields in ways that build individual and institutional capacity to achieve excellence, foster innovation, and ensure equity in health locally, nationally, and globally. DICP efforts support the career development of junior faculty, trainees, and students, identify and train leaders in academic medicine and health policy, and provide programs that address crucial pipeline issues. It is also part of our annual lecture series through the Equity and Social Justice Initiative, which was established to address issues related to health disparities, social determinants of health, leadership in the health systems, as well as health policy and other affected areas involving vulnerable populations. ESJ events focus on four main areas, including history and content, culture and environment, health disparities, and leadership and skill development. Before we get started, just a few housekeeping notes. Chat is not available and microphones will be muted, but please use the Q&A to pose questions to our panelists. The webinar is being recorded and will be posted on the DICP website. And now I am pleased to introduce you to our panelists who are going to lead this discussion, try and answer as many questions around these two very important topics, and to really open our thoughts as to how we can do better as physicians in training, others in the healthcare workspace to better care for ourselves during these really stressful times. So first, I'm going to introduce Dr. Nkechi Kante. She is a training director at the Boston Medical Center Psychiatric Residency Program and an assistant professor of psychiatry at Boston University. She is also staff psychiatrist at Boston Medical Center Psychiatry Integrated Behavioral Health Clinic and an affiliate of Mass General Hospital Center of Women's Health. Dr. Kante completed her residency at Duke University Hospital and has a graduate degree in public health from Harvard School of Public Health. She is the recipient of numerous awards for community service and academic excellence, including the Duke Department of Psychiatry Carter Community Service Award, the American College of Psychiatry Fellowship, and the Group for Advancement of Psychiatry Fellowship, and the Association of Women Psychiatrists International Fellowship, and the American Board of Psychiatry and Neurology Innovation in Education Faculty Award. Her expertise includes medical education, global psychiatry, reproductive psychiatry, community mental health, and health equity. Next, I will introduce Dr. L.A. Alvarez. He is a national leader and educator in wellness and diversity, equity, and inclusion. He is a clinical associate professor of emergency medicine and the director of well-being at Stanford Emergency Medicine. He co-leads the Human Potential team. His work focuses on humanizing physician roles as individuals and teams by harnessing our individual human potential in the context of high-performing teams. So with that, I want to say thank you and welcome to our two panelists. And I want to open it up and just start with a general question, really focusing on where we are at. And so the first question I'm going to turn to you, Nkechi, is how does burnout differ from other mental health disorders, and what are the unique challenges that or differences that present for the diagnosis and treatment of physician burnout?
Thank you so much, Alden, for having me here and for that question, which I think is very pertinent to today's climate, both social, cultural, and politically. I'll say, first of all, it's important to define what burnout is, right? So, burnout has been referred to as an occupational syndrome, right? And it's characterized by three traits, specifically emotional exhaustion, depersonalization, so seeing patients, colleagues as objects, and a reduced efficacy at work. But what is unique about burnout and differs it from psychiatric conditions, it is truly a workplace specific syndrome. So it's related to the work environment. Whereas other psychiatric conditions like depression, they're prevalent in every situation, in different situations. So at home, on vacation, postpartum, psychiatric conditions will be present there. Burnout will not be present there. And this leads to the other difference that even though they share some similarities in terms of symptoms, the symptoms of psychiatric conditions are more generalized. So changes in sleep pattern, changes in appetite, changes in mood, right? But for burnout, it's specific to the environment. So talking about the unique challenges to addressing burnout because of these differences, I think is inherent in what I just explained. Both of them are associated with a stigma, burnout and psychiatric conditions. However, in terms of access to treatment or access to care, depression is more likely to be noticed by people who are close to you, by family members, by friends, and they're more likely to urge you to get into treatment. In contrast, burnout is more likely to be noticed by people who are in a supervisory role or have an evaluative position over you. As such, there's a risk of a punitive component to the urge to seek care. And it's more framed as you need to do better. You need to work harder. You're not meeting your metrics. So there's more likely a challenge that way with burnout. So the person is less likely to get encouragement to seek help. The other difference I would say is with psychiatric conditions, the challenge of burnout compared to psychiatric conditions is no matter where you are, the medications, the treatments are more or less the same. If you're in South Africa, if you're in Namibia, if you're in Los Angeles, it's medications and psychotherapy. For burnout, it's unique to the workplace environment. And so the treatment, the remediation has to be related to the workplace and often involves systemic changes and external factors, right? So it's more than what the person can do. Actually, the person might have no control on how they're able to handle the situation because a lot of this is external to them.
It's interesting, and just for the audience to know, we had some scripted questions that are prepared, but immediately I want to sort of go off script because I think you made some really important points that I would love to tease out a little bit more. One is you mentioned that the recognition that happens is often from individuals in the workplace as opposed to home, and how that can be viewed negatively as far as like how you're performing at work, and how you are interacting with your team, etc. And I just wonder, as much as this is sort of a place-based type of impact, how much of this tends to bleed over into our personal lives? And so number one, and then number two, just thinking about this for some of us who are in a supervisory role, how do we make it so that instead of thinking about this from a punitive perspective of, hey, you're not doing your job, um, you know, it's in making this a negative interaction, how do we turn this into a positive, supportive interaction?
So those are great questions. And let me give this analogy. I think to simplify my response. First of all, complex answer. I would say it's similar to physician burnout. Let's say you're a runner on a marathon, right? The road gets twisty, windy, and you fall and sustain a sprain. With rest recovery, you can get better, right? But if you do not have the time to rest and recover, if you don't elevate your leg, if you don't wrap it up, you are at risk for permanent damage. Similarly, if you come back to the same twisty, windy road and there are no changes, you're likely to have another sprain. You're likely to have another fall. This is where the leading towards permanent damage. If a person with burnout does not get what they need to come out of the burnout, this is when it becomes bleeds into their personal relationship. This is when we start to talk about depression. Like I said, burnout, a sprain can become a fracture, an injury can become worse. The fracture in this case would be the depression. And that's where it's key for, to your second question, for supervisors to make sure that whoever is experiencing burnout within your system that you're supervising, it doesn't lead to something worse. One of the ways is what institutions have currently started doing is wellness checks. It's having meetings, it's having open forums discussing wellness and well-being. I will say since 2020, since the pandemic, there's been so much data that has shown the necessity of having wellness, of having investments in wellness. So many institutions across the board have started to incorporate this as part of their plan, as part of their metrics. When you're meeting with your chair, they're talking about how are you doing at home. They're looking to parental leave and making sure you get the parental leave that you need. They're looking into other factors and they're adding this to the metrics and giving you a more holistic review.
Awesome. I want to go ahead and loop in LA in this because I saw his head nodding and I know there was some agreement in many of the points that you were making, LA.
Yeah, and I just want to make it explicit because we're amongst friends and colleagues that we're going to be a first name basis because I would hate keep on in my mind. I was like, I should say doctor. So now that I said that, yes, there's a few things that I just wanted to follow up. I really love what Nkechi said about burnout as a syndrome, and the WHO made that they actually had it's an ICD-10 code now in 2019, but they were very explicit about calling it as an occupational phenomenon versus a medical condition. Because I think once we pathologize burnout, then as Nkechi pointed out, like it puts the onus on the individual to then either seek help, get treated, and then deal with that. What I love about it having an ICD-10 code is that now we can actually study this better. We can track how often are many of the conditions that we're treating related to burnout. So I think that's one that's a very, very important. Another thing that's Nkechi pointed out is this systems-wide approach to dealing with it. In fact, the IHI, the Institute of Health, initially had this idea, the triple aim. So if you recall, in 2007, we were expected to improve patient care experience, improve the outcome, and also lower the cost. And then in 2014, so actually like way before the pandemic, we started including, we called it the quadruple aim, this idea that clinician well-being is important for us to drive change in healthcare. And then it wasn't until 2021, driven by what was happening with the pandemic, and I think relevant to the conversation here on health equity and social justice, that health equity is now part of the quintuple aim. And so unless we really incorporate this in the drivers and metrics that we see as success and problems within our healthcare organizations, then it still falls on me as a doctor to then seek help for experiencing burnout. The other thing that I just wanted to add is your question, Alden, about the impact of work. There's actually a term for that. We started measuring that here at our institution and through WellMD. It's the impact of work on personal relationships. And it is pretty staggering that there's a dose-dependent impact on our personal relationships whenever there's inefficiencies at work. So at every level of inefficiencies at work, there's a higher level of impact on our personal relationships because of our work. That may be because I stay longer at work charting, or I spend a lot more pajama time or time, I call it uncompensated or unaccounted hours that we do to do some work because it's beyond our clinical shifts.
And it's great that you jumped in, LA, and we're going to have a bigger discussion around some of the comments that you made, specifically that we started talking about this in sort of the peri-COVID space, post-COVID space, but this existed well before COVID. I think we've just actually become more comfortable with talking about it. We probably just saw a lot of our colleagues just doing really bad at their job. It didn't have a name for it because they were dealing with burnout, but now we're actually calling it by its name. So thank you for that. And Casey, I want to turn back to you because with our focus with our equity and social justice lecture series, we talk about the impact on minoritized patient populations, but also physicians as well. And so, how have systemic inequities in healthcare contributed to physician burnout, specifically to those physicians, those providers who are coming from underrepresented groups in medicine?
So, as someone who holds multiple identities, which will be minoritized in medicine, female, immigrant, Black, I think this resonates deeply with me. And I will say specifically what we have, just speaking from through a gendered lens, right? Studies have shown that women tend to deliver more primary care or preventative care, right? That if you have a female hospitalist, you have less rates of rehospitalization when you get to the hospital. There's data for that. Studies have also shown that women hold the majority of caregiver role when they get back home, right? In terms of burnout, so in terms of incentive, these are uncompensated roles. They're not paid for, unpaid labor, right? And then when it comes, you flip the coin towards incentives, there's a gender pay gap. Women are going to earn less than men in medicine till now. There are less women in leadership roles. So this is kind of like a perfect setup for burnout. You're feeling exhausted, it's bleeding into your personal life because you don't have time for your caregiver role, your job too, when you get back home. As if you're URM, you are more likely to work in an environment that cares for underserved population, that's less likely to have resources. So most of your patients will be Medicaid or uninsured, and you are doing a lot more case management. Studies have also shown that minoritized patients want to see minoritized physicians, so you are more likely to get questions. And just bringing in the pandemic, uh, as we all know, the rates in Black and Hispanic populations were very high. They were devastatingly high, and the onus now became on underserved URM physicians to take on a lead role in public service campaigns. So giving talks on vaccination, none of that was compensated, right? And these are systemic issues that the individual is not able to fix. So you have the moral complex of you want to help. At the same time, you're battling with, I can't change this. I can't get my patient insurance for the medications that they need. And this is detrimental to your overall well-being. Right? So if you're a woman, if you're an immigrant, who you're also thinking about, how am I helping people at home? If you're part of an underserved, underrepresented population here, you are doing even extra work to get your people who look like you the care they need, and you're not being rewarded or acknowledged for it. I know we have some follow-up questions there, but I want to pause there. I do think things have improved, but not all the way.
All right, so I think we've gotten sort of the general picture and some definitions, but maybe let's tease this out with some data. So what does the data actually say about physician burnout rates, and what's changed maybe since the COVID pandemic? If there's data from beforehand, I would love to hear that, but I'm sure most of the data is sort of peri-pandemic and then, like I said, post-pandemic data that we're dealing with.
So in terms of data, for the first time, I think since 2020, the burnout rate has reduced. It's 48%, right? So physician burnout is now 40%. In 2021, it was 53%. 48% is not still down to pre-pandemic rates, unfortunately. And also, that's the average data. So that's the average range. In certain specialties, emergency medicine is still as high as 65% today. What we have seen is since the pandemic, institutions, health systems started to pay attention a lot more because of the physician shortage that resulted from the pandemic. So having, I would say, our workforce right now, about 20% of our workforce, physician workforce, is 65 years old and above. 55 to 64 is 22% of our workforce. And so we're getting to a huge amount of our workforce that is preparing for retirement. Now, the younger workforce, with the pandemic, we had a lot of people leave medicine. A lot of people lost their jobs. A lot of physicians lost their jobs. We had major hospital closures. We had specialties that couldn't practice essentially because everything was shut down. Those people haven't yet returned to work. Those people were forced to find alternate streams of income. So in terms of burnout, we're doing better because there's more systemic, holistic investment into healthcare, but we're not still addressing the need that we have. And the burden is still on the physicians because we still don't have enough. As a program director, I will add, we don't have enough residencies in the US. When we have so many applicants, we don't have enough programs to train them. We still have unfilled slots.
I think you bring up some great points in LA. I want to turn to you as another EM doc in this discussion. In case you mentioned that our burnout rates in emergency medicine are high. And then she also mentioned residents and its impact on our trainees. And so a lot of, historically trainees suffered in silence, and I think our trainees are now speaking up more. But do you have any comments about one, our specialty in emergency medicine, and then two, any comments about what our trainees may be experiencing with this issue?
Yeah, thank you. So a few things. I think maybe if we can even step back a little bit of like, what are some of the drivers for these burnout symptoms that we're experiencing? I think one part is this idea of the imposter phenomenon that we don't often acknowledge. There's a study that shows that physicians have the highest imposter phenomenon compared to any other workforce in this country. And so just by showing up as a doctor, you're more likely to already feel bad that you're not good enough when you're taking care of your patients. Now, especially in emergency medicine, when we have this, the idea of the VUCA environment, we deal with volatile, uncertain, complex, and ambiguous environments. We then always, it's actually expected on us to second guess ourselves, to have the second backup, the third backup, the fourth backup. So if you're in that environment, and then especially if you're underrepresented in medicine, if you're women in medicine, when you're treated differently by your colleagues, by your faculty, and by your patients, right? So emergency physicians also historically experience the highest mistreatment from our patients, from the nurses, and also from our colleagues, right? As an emergency physician, when I call somebody, I'm giving them work. And so in an environment where there's a lot of work already in a complex system like healthcare, then it's not unreasonable. Well, I can understand why consultants can be not as kind when they respond to us, especially as a nocturnist. I call them in the middle of the night. And so I think that's one aspect of it. The other thing that it's important to note is that as part of the front lines, we deal with the failure of the healthcare system, right? And so when we talk about like health equity and social justice, and we want to do the best thing for our patients, right? And we cannot, either because the system is not allowing us, or because now the patient's condition is so bad because they didn't have any access to care earlier on. That puts us in this situation where we're constantly feeling moral distress. That betrayal, the betrayal of the system, that we don't have the right thing to do for the patient, and also the betrayal for ourselves, right? Like we compromise sometimes, like, yeah, but if I admit them, I'm going to be yelled at by ex-consultant, and so maybe we can just find a way to like tee them up a little bit and discharge them, right? We wouldn't have done that in the first place with any other patient population, but yet somehow, especially when it comes to those who are like not have access to good finances, then we somehow do less care. And then when we go home, then we internalize that. We feel bad because, again, we're caring people. And so imagine cumulatively, you deal with this, you don't get to talk to anybody about this because you think it's just you as part of that imposter phenomenon. And also as emergency physicians, we deal with this. The next part is vicarious trauma. The trauma that people are experiencing, we're also reliving that as we're taking care of them. And so there's this idea of residue that just accumulates. And unless we take care of that, I think that's why, especially in emergency medicine, we're more prone to developing these the symptoms for burnout. In fact, we train our folks to compartmentalize, right? Which is the not extreme version of depersonalization, right? I have to compartmentalize when I treat patients when there's like a lot of blood and gore in front of me so that I can actually do my job and not get sucked into the empathetic part, that empathetic distress that like, man, this person is suffering a lot.
Yeah. I hate to say this, and I don't want to make this EM specific, but what you said just really hit home with me and some of the experiences I have within the emergency department. So thank you. It's good to know that we share experiences, but it's also bad to know that we share experiences. So thank you for sharing. I want to unpack a little bit more about the post-COVID healthcare system and what's been the impact on physician burnout. We've seen hospital closures, contractures within the systems, financial constraints within our hospitals, the ebbs and flows with our nursing colleagues when it comes to travelers. There's been so many sort of disruptions within an already disrupted healthcare system. And so, what are the key challenges that are being faced by healthcare workers, and in particular physicians, right now that are happening from all of these sort of changes that are happening within our healthcare system?
I would say one thing that was totally related to the workplace, but really impacted burnout is the term is I did my own research. As a physician, when you're with a you have your medication, and this I think escalated during COVID with all the talks of like vaccination. I did my own research. I did my own research. I want this. Patients started to drive their care in a more specific way. There was a lot of misinformation, and that added to the burnout. So you were doing a lot more education, and you were being disbelieved. Like, no, literally, you would have a PhD in something, and then you'll be told no, and they will quote your research when they're telling you. That truly, I think, dramatically added to the burnout that physicians were having because we were no longer respected as the authority of our field, right? There was a lot of misinformation. The second thing, which ironically was supposed to improve access, and we just joked about it earlier, is telemedicine, right? So telemedicine improved access for some, not all. When we talk about underserved populations, not everyone. At the same time, it increased the amount of administrative burden that physicians had to go through. So you're working with Zoom, you're working with, if the patient were in front of you, you could have a conversation, you could talk about their medications, but now you're having a phone conversation, there's no internet, there's no Wi-Fi, there's no cellular data, you have to check in, you have to use a certain template, and it took a while for the resources, the technical support to catch up into integrated Zoom into your Epic system. So there became a lot more administrative burden through telemedicine, even though it improved access if your patient had access. If your patient did not, it actually deterred access. And we have data that shows that URM patients actually preferred in-person meetings because they thought that they expected to receive more dedicated care if they were meeting face to face because of medical mistrust. So those were the two ways.
So I'm gonna pause because I know that Nkechi mentioned that she was having some IT issues on campus. And maybe I'll turn to you, LA, and see if you can help finish out some of this discussion around sort of systemic changes that have impacted us.
Yeah, I think I was following Nkechi in the things that she was saying, and I think part of the issue is that the work that we're doing, I think the pandemic has made us realize that many of our work has been very transactional. And this idea that we don't see medicine and being a physician as a profession, at least from a patient perspective, right? That it's not a profession, that it's just a job. And while that is good, because then I can psychologically distant from work if it's just a job and not like my own identity. The problem though is that idea of respect. For years, way before the pandemic, there's this higher emphasis on patient-centered care. Your Press-Ganey score drops if you don't order that MRI or don't give this pain medicine for the patient because they're not happy, right? And it's actually a very dangerous practice. And also you can put that in the extremes where at some point at our institution, we had this like red blanket that you would give to VIPs to signal that they're VIPs, and they actually would get like less appropriate care because you would either order too much or not do anything for them because you're so worried about like the implications. What I'm trying to say is now we're like at our institution, we have moved the conversation from patient-centered care to relationship-centered care. There is value for me going to medical school, get the residency training that I've gotten to take care of my patient. And so it is that relationship that is a lot more important rather than transactional, like I have to bow to whatever the patient is asking me to do, despite knowing that it's actually not good for them. Again, that goes back to that moral injury, right? If I always have to do what my patient tells me to do, even though it's not the best thing for them, I'm not doing good medicine. I'm betraying myself. I'm betraying my profession. And the system is betraying me by then rewarding them by acknowledging those press gani. And also at our institution, we like several folks have shown that like press gani is actually biased against women and those historically underrepresented in medicine. And so we don't have press gani in our institution anymore, because that's a systemic solution, right? Like, because then like why use a biasing metric to then drive people to feel more burnt out and also give bad care, going back to the quintuple aim.
Yeah.
I apologize. I'm sorry. Internet issues. Maybe that was, they wanted to get back to me, the internet gods. But I would just add one more point. Just parenting became extremely challenging, and a lot more women left the physician workforce because of daycare.
Yeah.
Not being able, daycare closures. So talking about burnout, you're working from home still because you have to take care of a sick child, or you're not able to go to the daycare, given that a lot of the daycare personnel were those who are more at risk for COVID or the COVID sequelae. There was a lot of daycare closures. So if you're parenting as a physician, that was an extremely important. Having parental support in your department is extremely important to alleviate the stress of burnout. But again, how many facilities or institutions can provide that?
I will just add to that because I think it's worth noting, and Nkechi gave us some data earlier, that it's actually specifically impacted women in medicine, right? There is a double standard for women in medicine that they have to do so well at work, and at the same time, when they go home, there is this expectation that they also have to like cook, make sure that there's food is available. And I'm not saying that this is all true for everybody, but in general, that seems to be like a common theme that we notice in medicine. And I think that is like, I just wanted to say that out loud also, number one, for acknowledgement, and number two, so that we can like, in the future, really like advance that conversation to how might we work with the intersectionalities of our work to honor the added burden that people are taking on. We talked about unaccounted work. These are added unaccounted work simply because of marginalized status.
I think this is a great discussion. I don't want to take away from it because I really do think we, the fact that we're highlighting marginalized populations, specifically women here in medicine, knowing that, you talked about the impact of press gani scores and how there may be negative implications when it comes to women and how they're evaluated compared to their male colleagues. We talked about the burden that women are facing when it comes to that work-life balance, work-life integration, as we should be calling it probably more appropriately. And so I want to talk more about that. I just want to just close out this discussion on burnout because there are other changes that are happening in medicine, specifically with private equity, hospital closures, purchasing and selling of physician practices. And like, how is that actually impacting physicians, especially when it comes to the space around clinician autonomy and retention? We talked about how people left the workplace in around COVID, after COVID, and they haven't returned. There's been a lot of changes and upheavals within the system that are impacting us, and I would just love to hear a little bit more about the impact of medicine as the business, as opposed to medicine as you were talking about at LA, a calling or a career as opposed to just a job. So, and Nkechi, I'll go to you first, and then I'll jump to you, LA.
It's the reduction in clinical autonomy. I think that's the biggest impact that private equity has had on physicians. If you're someone who derived joy from your work and making decision, making our Ellie, I love the term relationship centered care. Like you want to have a relationship, you want to have a say in what you're doing with your patient, with your team. Private equity took away from that. It increased job dissatisfaction, right? It led to a lot of clinician turnover, right? We've talked about moral injury today, and leading to the fact that as a physician, you have this ethical decision. You know what you want to do for your patient, but you're not able to do it because of financial metrics. That's really, I don't want to use the word traumatizing, but that's really impactful on a person's well-being. So that for me is the biggest impact, the most significant impact that private equity has had. It's more about the figures than the people and the lack of autonomy.
LA?
I will follow that with for me, whenever I do work on either spaces, um, uh, well-being or in the space of inclusion and belonging, I try to simplify it to like the self-determination theory, autonomy, belonging, competence, right? The ABCs. And as you said, like Nkechi pointed out, like that private equity has led to the loss of this autonomy and actually a loss of this sense of belonging, right? We are replaceable. I do not have any notion that as an emergency physician, I'm not replaceable. We are. That's actually the very nature and the good thing about the specialty in some ways, because if I get sick, Alden can take my shift tomorrow and my patient would never know that they're being treated by a different doctor, right? For them, it's just a doctor that's treating them. However, the problem with that, if you don't really create a sense of belonging within your community, within your department, within your institution, or especially in those environments with private equity, would just easily replace an entire group of emergency physicians because there's a better contract that's cheaper. Then you get this idea that, you know what, the institution does not care about me. I am replaceable. We are all replaceable. And so then should I just quiet quit and just show up and do my job and not do any innovation? Or if I truly feel like I have autonomy, belonging, and competence, then I can actually push like things like this. I get paid to be here right now to talk to us, to have this discussion about the wonderful work that we do on physician well-being and burnout, right? Not a lot of people get to say that because they're so worried that we're so replaceable. I think that is, for me, it's a very practical, real example of the differences of being in a private equity environment or being in my case, in an academic environment that actually supports innovation in this space.
So thank you for really sort of both of you honing us in and sort of talking about the burnout aspect. But I want to flip because and use the remaining time to talk about the wellness aspect of this discussion, and keeping it on this big picture, because we've talked about private equity, we talked about health systems in their roles that they've played in leading to physician burnout. Let's talk about what system-wide changes can happen at that systems level, that big umbrella of what can be done, what can be implemented to improve physician wellness and to reduce burnout.
Number one, I think we have to humanize ourselves. From an institutional level, we have to humanize doctors as humans as opposed to this replaceable thing, that this entity that like, this is just like a grocery store that I can just like talk to somebody and then like, and not care about them, right? We're dealing with human beings. And so Shanafelt and team like published this article on well-being or wellness-centered leadership. And at the very foundation of this wellness-centered leadership is care about people always, right? So caring about the physicians, the nurses, the staff as part, again, like when we talk about the quintuple aim, clinician well-being is part of that, is integral to the success of a healthcare system. And then we have to move away from this us versus them, right? Like this idea of like, well, the institution does this and therefore like they don't care. that may be true to highlight the differences and the problems, but it doesn't get us to solution. For me, in order for me to actually like drive change in our department or in our institution, I have to be able to learn the language and communicate with the leaders so that we can find alignment. Because in the like at the core of it, they're also just as human who cares about us, who may not have the cultural empathy of what we go through as emergency physicians, who may not have the cultural empathy to experience what it's like to be a nocturnist. And so by having that like collaborative approach, then we can cultivate the relationships for individuals and also for teams. Like that is the essence of the human potential team. Because then once you do that, then you can get to the pinnacle, which is then you can inspire change. Now, this is a very theoretical model, but I love how it's like, again, framing that we have to care about the people always. We have to cultivate the relationships, and then we have to then help those with autonomy, belonging, competence, help people inspire change.
Thank you. And KG, I want to turn to you in a different role, and I mentioned it in reading your bio. But you talked about, being in program leadership, being a program director. Ways that residencies can think about how they can mitigate burnout and reduce, this distress that our trainees may be experiencing. And I know you mentioned more residency slots, but it's not just a numbers game. It's other things that we can be doing to really support our trainees in this space.
I would start with mentorship. I would start with mentorship and incentivizing faculty, physicians to be mentors. I think that's super important when we talk about practical ideas, how we have a lot of things. And I'll say specifically for URM mentorship, studies have shown it's harder if you're a URM physician, resident, to get the mentorship that you need or to establish a contact. But historically, there hasn't been really mentorship around community support. And LA talked about belonging and feeling part of the team. How much mentorship do we have regarding community support? Not research mentorship, not specialty mentorship, which is incentivized by you can put your mentee, how many mentees for your research on your CV and get promoted for that. But if you're being minority taxed to be a mentor, where did that turn up in your CV? If you're providing here, like Alden, you have a great team that you do going to all medical schools talking about what it means to be Black in medicine. How much of that is rewarded by institutions? I would shout out Harvard for doing putting DEI as a segment in promotion. So if you're doing DEI work, if you're doing not previously uncompensated work, you now are incentivized and is now eligible for promotion. But how many other institutions are doing that? As a residency, a program director, one of the things that I personally want to do is mentorship, particularly for those who have underserved, who are less likely to be able to establish the mentorship, and getting rewards for those who are taking the time to mentor. I think that's extraordinarily important in our system.
Awesome.
Can
Thank you.
I add to that, by the way?
Please.
I think it's important to have a framework here that like, I love mentorship. I think it's very important because it adds to the sense of belonging. I believe that that's part of the culture of wellness. And the other part of this from a systemic institutional support is we have to really improve our efficiencies of practice. I mentioned that earlier. There's a dose-dependent impact on our personal relationships when there's inefficiencies in our work. And that is not on the individual to fix. Like that is an institutional support to advance it. So I'm glad that the conversation is less about like personal resilience. You have to just resilience your way out of this, and more about really creating cultures of wellness and efficiencies of practice. And that's what we use in the professional fulfillment model. And also I think important to understand that like, yes, like there is burnout, but I think it's important to move the conversations from the pathologizing it to focus on professional fulfillment. I can be burnout and still have professional fulfillment. I think we have to separate that one is the opposite of the other.
Awesome. Yeah, resilience and grit, right? That's what we were, it was drilled in our heads so many times. But I think there are realistic strategies that we as physicians can use to maintain that healthy work-life integration. And so can you talk to us, LA, about what are some of the strategies that you may use or that you do in your coaching and your mentoring, especially with some of the younger folks that you work with in this space?
Yeah, so specifically in the context of work-life balance, part of balance is I need to be kind to myself. So this idea of self-compassion, there's actually studies that show that the kinder I am to myself, I'm more likely to sleep better, right? And also there's studies that show that physicians in general have lower self-compassion compared to any other workforce in this country. And so then we have to work harder on developing that. And there are systematic way to develop self-compassion. We can support each other, but at the core of it, if I'm not kind to myself, if I'm constantly worried about my imposterism, if I'm constantly worried about making mistake because I don't get that sense of belonging, then I'm more likely to not thrive in that environment. And so that's one thing, right? So boundary, the way that I can actually set boundary is part of my self-compassion. I go on vacation twice a year, every year for at least 2 weeks. And that is actually like a systems-wide thing that we do in our department. Every 6 months, our medical director sends us an email. Here, like, can you send us like you can like vote like up to like 6 weeks. Like you can rank like which 2 week block do you want to take off as a vacation every 6 months. We just do that because we believe that that's important. And then there's a recent paper that just came out that physicians in general actually do not take vacations, right? We're terrible at it, especially in the United States. Like to the point that I think the number is like out of like 3,000 physicians, the number of vacation days taking and performing patient-related work while on vacation was associated with burnout. Like Alden, I remember you said this or you tweeted about this. You delete like your email app from your phone when you travel, when you're going on vacation, right? I learned recently that I can actually just turn up the cellular access to all of these like apps. I don't have to delete it. I just turn off the cellular access. So now I'm again, it's just developing ways to prevent me from like reaching, because it doesn't mean that I don't care. I actually care about work, but I'm much better person. I'm a better clinician when I take a break from work.
I almost feel like go ahead,
I'm sorry.
Kechi. I just want to say this one thing. I almost feel like LA was picking on me with the first part of that discussion because like you were talking about the self-compassion and and all of those things. And I was like, yeah, that sounds a lot like me in some of the times, especially early on in my career. And I think as I've been doing this a little bit longer, I've matured and sort of thought about this my approach to medicine a little bit more from a self-care perspective, as opposed to, this is the grind, this is the space I have to be in.
Self-sacrifice.
Yeah,
That's right.
yeah. Go ahead, Nkechi.
And so I just it's resonated so deeply with me. So I have a work phone. So my email is not even on my personal phone. I have a different phone as part of my wellness
I
journey.
love
It's
that.
just I have a separate phone for work. So it's when I get home, if I don't email, even if I'm tempted to, I don't have my work phone on. I will say that part of the reason why I came into residency education is noticing this imposter syndrome, people say type A personality, but just this drive to be best, this fear of being evaluated as inferior in your work that a lot of residents, particularly URM residents, were facing and voicing. And the fact that as a resident program director, I've had to send emails to residents to take vacation.
Yeah.
They haven't taken vacation. It's almost the end of the year. Just a reminder, you have to.
Yeah.
So I will add by saying check-ins, instituting check-ins with your team, with your personnel, with your supervisor, regular check-ins. It shouldn't just be when there's a disaster approaching. How often are you checking in on yourself with your supervisor or with your team, or arranging check-ins with other people that you work with? Let it be something that you do every 2 months, every 1 month. Setting appropriate boundaries, teaching my residents after work hours is not the time to send an email. You should be resting. You should have dinner, right? If there's anything, let's schedule for the other day. Using Microsoft Outlook to schedule send things. So even if you forget in the morning, schedule send it for 8 a.m. Some people have a byline saying, oh, if it's after work hours, do not feel pressure to
That's
respond.
me.
I think individual things you can do and you can model for trainees that you work with, right? And they can pick up these habits, which leads to the self-compassion that helps their wellness overall.
Mm. Yeah.
And also like again, we can do this as individual practice, but we can make this like as an institutional movement. Our department chair, right, under Blomkans, when she started in our department, she's like, I don't want to see emails after 5 p.m. Like literally, actually, like I sent an email on a Saturday because I forget my days because I'm a nocturnist and I usually work weekends. And then she sent me an email. She's like, LA, for a wellness person, you're sending an email on a Saturday. I was like, oh crap, right? So now I send later for all of these things. It doesn't mean that you're compromising your own self, right? Like I also don't want to do work when I'm like post overnight because I have to like work with everybody else's schedule. But there is no technology that allows us to do that, right? To send emails later. So that's one thing. And another thing that, and I think it's just very much important to highlight, your resident who's not taking a vacation because they're working, it's not because they're bad people. We actually selected them for this, right? It's part of our selection measure. They work really hard. Now we just dialed it too much because it's that fear of failure. We have to start moving to like the motivations of like actually like motivation of self-compassion, and especially as leaders, there's also several papers out there that highlight that as a leader, how kind you are to yourself, how much self-compassion you are, is equates to how effective you are as a leader. So we have to work on it from a leadership level and not just at the individual level,
Mm.
including our boss
And
taking vacations, right? If my chair does not take vacation, then it doesn't matter because then it doesn't signal to the world that vacation is important. And so like when my chair went on vacation this a couple of months ago, I sent her an email when she came back the day of. I was like, I'm sure your inbox is very full because everybody knows that feeling. I just want to thank you for taking a vacation because it's modeling for the rest of us that vacation is good.
Thank you.
one point I will just add to this is, in terms of systemic ways to include this, I really respect the residency teams for creating a contract, unionized, right?
Yeah.
This is a way they're harnessing their power to implement wellness as part of their contract. So that's just a shout out I'll give to PMC. We have a very strong resident union, and now as a program director, I'm equipped to enact these measures, these wellness measures, because now it's legal. It's in the contract.
So I just want to be cognizant of the time that we have and make sure that if there's any questions from the audience that you please use the Q&A function. I am keeping a track of that, and I want to integrate your questions. So if you have anything you would like to bring to our speakers, please drop that in the Q&A. But while we're having this conversation, you talked about the unionization of trainees, but LA, I would love to hear more about ways that as we grow in this discussion around equity and justice, and we think about it from a patient perspective or from a community perspective, how can we use those same thoughts, those same feelings, those same ideals towards our physicians as we try and address this issue around physician burnout and promoting wellness?
Yeah, I think for me, put simply, we're just as human as our patients. And so whatever is impacting the systemic inequities that impact our patients also impact us. If the environment is not set up for me to do well as a physician, then I'm also gonna do worse, right? So practically speaking, that means like not having silos of work that's focused on DEI versus work that focuses on well-being. I think that has to be integrated. And the connection there is actually focusing on a sense of belonging, right? A lot of the work that we do in our department, for instance, that you mentioned earlier in Keiichi, the idea of like supporting parents. So right now we're revising our work, family, career guidelines. Things like if you have a new kid, you shouldn't be on call for the entire year because we know that your schedule is going to be so disrupted already by having a kid. You shouldn't do any overnight shifts for the entire year. And we've been doing that for years in our department, but we want to put that in writing. Things that are really like focused on, right? Focus on making sure that we care about our people and we get it. We get the struggles that we're having, and we chose this hard path. We chose to be emergency physicians, and we know that we have the highest burnout in all of medicine. And knowing all of that, what are ways that we can do to make this environment better for ourselves? Because then when you have clinician well-being as equal priority for as part of that quintuple aim, then the rest of those will also go up. We give better patient care. Cost of care is less because we're less about like defensive medicine practice. And also we get to go home on time to be with our family, to take care of our family and to take care of ourselves.
I just really appreciate the fact that you're tying this into the things that other people care about, meaning you're talking about outcomes related to patients, you're talking about dollars within our healthcare system, and the link that you can make from a burnout physician to a physician who is well, to the care that they provide for patients, and to the numbers, the things that people who are, caring about the dollar, the bottom line, the dollars and cents may actually care about. It's good to see that there is, continuity in this discussion, and it's not just physicians need to be well so they can be well, or physicians need to take vacations so they're not burnt out, but it actually translates into other aspects of medicine that so many people care about, and so that model of taking it from triple aim to the quadruple aim and so forth is really, really helpful. And I really just wish we would think about this more, than it's on the provider, it's on the physician to be well. And let's think about what the systemic implications are, for these spaces.
Well, also financially, it's expensive, right? At Stanford, it costs about $500,000 to $1 million to replace one physician who quits because of burnout. That is pretty impressive.
Can you just say that number again? How much?
$500,000 to $1 million, depending on your specialty, per physician. That's the cost of their inefficiency, the cost of recruitment, the cost, like there's a lot of these things that's attributable to a physician burnout that quits. There's actually data for nurses as well. So like we have to start, if we look at it like, but this is why it's not us versus them. We have to learn the language of communicating with leaders, right? So that we can really focus on the solution as opposed to just like feeling bad that I'm the victim here. I'm not a victim. We actually have ways to address this, right? And that gets to autonomy, belonging, competence.
This was such a stimulating conversation, and I want to thank the both of you for being a part of this. I want to ask very quickly, just in the interest of time, can you tell us, in LA, there's going to be a question in the chat, so I'll toss that to you, but I'll go to Nkechi first, and then I'll go to LA. Tell us one walkaway point that you want us to know. Maybe it is directly to someone in the audience about what they should be doing. Maybe it's a leader within the healthcare system. Just one walkaway point that somebody should implement today, for physician wellness.
Boundaries. Set appropriate boundaries. Set appropriate boundaries with patients, with colleagues, with your family life, with work life. There are little tips you can do, like not responding to emails after 5 p.m., not scheduling meetings on a Friday afternoon or on a weekend. So for me, that's the takeaway point. Learn the art of establishing boundaries early in your career, even as a medical student, and that will serve you well as you go forward in your career as a physician.
And LA, I'll turn to you. Similar question. And then if you want to try and address the question in the audience as well.
Yeah, I'll connect that together. So it's self-compassion or self-valuation, whichever you want to use. And that is understanding the common humanity. You mentioned that earlier, right? There's some resonance with what we're talking about. Yeah, because we're humans and we're experiencing the same thing, and knowing that we can be kinder to ourselves and we can be more self-aware when we're actually sacrificing or betraying ourselves. So the answer to the question, like what can a pre-med student do? Start learning practices to like be kind to yourself. And it's not easy to do that, but part of that is to accept your own imperfection in order for you to have that growth mindset. That is the definition of self-valuation, right? And we can, each and every one of us has the capacity to develop that. And so once we have that, we can then advocate for change, not just for ourselves, but for the environment that we're in. But we have to be kind to ourselves.
And you can learn that through psychotherapy.
Yeah,
that's one thing.
Or compassion cultivation training, and there's many ways of getting there, right? But it can be done, and you're not broken.
So in a few seconds, you're going to see a quick survey that's going to pop up on the screen. Feel free to complete this survey. It's just helpful for us to think about how we move forward with future equity and social justice talks. But in the meantime, I want to say thank you to my two friends, my two colleagues, Dr. Conti, Dr. Alvarez, for being here and joining us in this discussion. I felt this was extremely stimulating. I felt personally moved by this discussion and thinking about how I treat myself and how I can be a better mentor, how I could be model wellness better for my colleagues. So thank you for that. We will be having future equity and social justice events coming up with the theme around wellness, physician burnout, and mental health. That is our focus for the year. So be on the lookout for future equity and social justice discussions coming to your inbox so you can sign up and register. Thank you to Lynn Fulton John in the background for helping us to have another amazing event. Please remember that our ESJs are recorded, transcribed, and will be available to you for this for your viewing and future use and review in the next few weeks. But again, thank you to my two colleagues in Nkechi and LA for being here. And I hope everyone has a great rest of your day and focus on your wellness. Take care.
Thank you.
Thank you.